Okay, so we'll get started here. We're going to start a little breakout session the next couple months for cardiac devices, specifically the left ventricular assist devices, balloon pumps, Impellas, specifically implantable VADs, and eventually, hopefully in January or February when I get back from the conference, just a little info on ECMO. We're going to start with the Impella. And you may ask, first of all, why do you care, especially if you're leaving here and you're not going to fly afterwards? What do you need to know about these devices, and how am I going to manage the Impella either on the floor or in the helicopter? So again, why do I care? I'm not going to be flying. Can't I just call the final location for specific orders on these devices? And they're uncommon. We're never going to see them. No one uses these things. Well, for just about every device, the frequency is increasing. So things like the VADs, UT is no longer doing VADs, so they are coming here. We've had 2 cases in the last couple months, actually, where we had one person almost die because they came here and had to get flown to UTMC where there was a VAD battery. Right now we actually have VAD batteries, from what Clay has told me, in the ER, so if someone comes in and their battery is dead, you will be able to save their life without having to fly them across town to UTMC. So unfortunately, deteriorating patients may end up in your ER in the future. So wherever you are, most HEM services, if a person has an arrest or peri-arrest, they're just going to land in your backyard and they're going to deliver. Medflight's a perfect example. We went straight, this person's deteriorating, you're going straight to the nearest ER. It doesn't matter where it is. So you may walk in or get a call to your helipad like, hey, we have this patient who's coding. Well, now you need to know how to manage the device because it's at your door. Can I just call the final location for orders? Yes, you could call the VAD, or the Impella rep. Unfortunately, they don't always pick up. Surprisingly, you're not a cardiologist. You don't have the number they care about. So you may need to figure this out by yourself for a little bit of time. And unfortunately, these devices are becoming more and more common as people are trying to get off of using high-dose vasopressors for their cardiac patients. They're trying to switch more to using balloon pumps and Impellas in order to try to offload some of that work on the heart. So places like Bryan, Ohio, Firelands, possibly even Tiffin in a few years. The cardiologist already has a non-interventional cath lab there. That's usually like the first step in trying to make your interventional location. So when you get these patients, they may end up having. Also, when you're at places, you may be responding to codes on the floors. You need to know how to use these devices, or at least get the simple management of the devices. So again, what if you're at a small community ER and your patient is hitting the helipad and they just lost pulses and they're a few minutes from your location, VFib, compressions in progress, and you figure out, well, they have an Impella device in place. How are you going to manage this CPR? How are you going to manage this code? Because there are some differences with this kind of management than a standard CPR patient. So especially with the Impella, they may not even have a pulse. So who do you call for help? It's not Ghostbusters. So we're going to just go over how this is what this device is. Basically, it works the same on principle as the implantable surgical LVAD that basically removes a chunk of your heart, except in this case, it's temporary, so it goes across the aortic valve and basically is inserted by either a heart cath, or temporarily they can actually place it surgically, and the one they place surgically actually can completely overtake the heart. So it will, if you get someone from a cardiothoracic team, they may have one that completely takes over the work of the heart. So reduce the workload on the left ventricle, again, depending on the model, up to half to over up to full cardiac support based on the device. It reduces your end diastolic volume, therefore it reduces your end diastolic pressure, increases the MAP and therefore the flow of blood through the system. These are the different models you're going to have. The 2.5 is probably the most common one placed by most cath teams. This is the one that's, hey, they're a stable patient. This replaces your balloon pump in a lot of places because it provides about as much support as that. The Impella CP is actually much higher flow rates, up to 3.5 liters per minute on the heart. Offloads the heart. The 5.0 is the surgical implanted one. This can take 5 liters per minute and basically completely can overtake the work of the heart. There is a right-sided version. These are extremely uncommon, but can be placed. And then that's the Impella controller. So some of you may have already been with me when we've gone to the cardiac ICU and actually gone over these devices. Anytime there's a device placed, the goal is to have the Sumaludi, the lead RN there, call the residency, let me know when these devices are placed, including balloon pumps, so that we can get you guys down, rotating in there a little more, rather than just showing up when it's your patient or you're on rounds. So, typically works like a propeller mechanism, again, similar to the rotary motion of an LVAD, except again, it's placed percutaneously and can be removed. It uses a negative pressure driving force, so therefore it's preload dependent. So the motor sits here, spins, pulls blood through, and again, you have that negative pressure here to push blood out this end. Other way around, sorry, flip that upside down. Again, it's preload dependent, so someone without preload is going to have problems, and you need to remain across the aortic valve. So this needs to sit across the aortic valve. This is in the ventricle. Here's what's in the aorta, and this needs to sit across because you need the inlet and outlet on separate sides of the valve, because that's going to be your check to make sure there's no retrograde flow. So physiologically, it requires a CVP of greater than 10. Otherwise, you're not going to have enough volume in the left ventricle to actually pull it out. As your systemic vascular resistance increases, so if you have your swan in and you're finding that the patient has an increased SVR, that actually puts extra work on the motor and can actually reduce your flow rates. You may actually feel weak pulses, or you may not be able to feel pulses. So just because someone's in VTAC, this is where it becomes very important to use your ultrasound to figure out the map, or use your arterial line to figure out what the map is, because if someone has a map that's 50, 60, and there is a little bit of wave variation, that VTAC is not something that needs compressions. This is someone who needs defibrillation. So again, you're going to treat on the map, not on the SBP, because again, these patients like LVAD don't always have a pulse. And again, using your ultrasound can be real helpful. Again, this is why Life Flight 4 is going to kind of be our primary base, because you guys have so much more abilities with the ultrasound and being able to figure these devices out than any of the other crews. It does require a purge solution to protect the motor. So that purge solution is basically like the lubricant that keeps that propeller from clogging up. So if blood gets into that propeller motor housing, it can disable the whole device. It's just like a clot would on an LVAD. These patients also need to be anticoagulated with heparin or heparinized. So this is a little card that you'll find usually on the Impellas in the hospital or in different locations. It's based on the device, and a P level is your performance level. It's how fast the RPMs, how fast that motor is spinning. And based on that P level, you can actually get an estimated flow. So if you come in, you see a patient on the ICU or wherever, and they are having a P level that's, you know, very different from the flow rate. So perfect example, the last transport I did, person was at a P1, which really is only used for insertion and removal, but their flow rate was like 3 on a CP, which is pretty high. I was like, there's something wrong. We went to the placement screen, we identified that it wasn't across the aortic valve, so it had to be adjusted. So that's one way you can figure it out. The other thing is, if someone's on, you know, the horrific medication like, you know, phenylephrine, which is absolutely horrible in these patients, because it increases, all it does is increase your SVR. It basically will make it so you may be at like a P7, but you're only getting a flow of like 1.7 liters per minute. You're getting a real low flow because of all that systemic vascular resistance. So again, the CP gives you a lot more, and in our case, again, they were at a P1, but we're getting flows way up here because that catheter was sitting either, actually in our case, it was sitting in the aorta. So think about that. It's like putting your car in park or in neutral and just revving the engine. It's not doing anything. It's just spinning and just putting blood flow back into from moving it from the aorta into the aorta. So here's what the device actually looks like. Again, this sits across the aortic valve. You have your, you know, centimeter markers to tell you how deep it is. We do have checklists that you'll have, and again, if you're on the floor and you ever need them, just, you know, get them off the protocols because for LifeFlight, because they're actually pretty good, and it can go through a checklist of everything you'll need. You know, whether the depth is appropriate, whether the connections are tight, you know, stuff like that. That just, if you're in the heat of the moment on the floor, it's, you know, 2 o'clock in the morning, you don't know how to manage it. It'll give you that assistance. Also, when you're on flight, we want you to, you know, fill it out, and actually, Amy did a great job with some EKGs, just putting the EKG pictures on the chart. So this is like one of those things we really want this on the chart. This is, of course, your sidearm for your you know, purge solution. This device right here is an older one. The newest devices that they're coming out with actually do not even have the pressure sidearm port for the BP, the aortic BP line. So the newer ones, you still see some of these. There's still a lot of them out there, but the newest devices don't have that red pressure sidearm port that's basically just works as an arterial line. And again, this you see here, the, you know, clear sheet, same thing as when you guys put in your transvenous pacers. So when you're putting in a transvenous pacer, it's closed, so you can advance or pull back and keep that patient sterile, so you don't need to re-prep and drape that patient. Again, really should be doing that, again, with ultrasound guidance, but again, we'll have that on our flights if we absolutely need it. Again, that's not something you want to do in flight. It's one of those things, let's try to address it before we leave. Frequency of utilization, again, is increasing. More sites are using them, so we're going to see them. You may see them when you respond to codes on the floors at night, and especially if you're at a location like Firelands or somewhere where you're the only one in the hospital, perhaps at 2 in the morning, you may end up having to, again, take care of these devices outside of just flight. So there's a patient checklist. Biggest things is you want to make sure there's pulses in all extremities. A lot of these patients don't have pulses to begin with or have very weak ones. So assessing flow in all extremities becomes really important. These are very, very large catheters, sometimes 14 French in the groins. So if someone has a, you know, occluded limb that becomes, you know, blocked, and you want to make sure that you've documented for your information that you had pulses when you had it, or in our case with the ECMO patient that was on the Impella, they didn't have pulses. And we clearly documented it at both points, because again, that person may lose that leg. Again, you want to know your current Impella settings, so, you know, being able to continue those becomes very important, especially if you need to make any adjustments. the head of the bed for all the percutaneous devices, not the surgically implanted one, the patient needs to be relatively flat, less than 30 degrees. Again, you want to know if there's any hematoma, catheter depth, and then all lines are tight and fitting. Again, you need to know the ACT and ensure you have enough purge solution for transport. So the reason that's important is because it's a heparinized purge solution, because you need to keep that patient anticoagulated. So we don't carry a heparinized purge solution readily available. It usually needs to be made by pharmacy. So if your bag is almost empty, just make sure you're going to have enough for the transport. Again, hematoma becomes really important because, again, these people are anticoagulated, and depending on how rough the Impella was inserted, you can't have a retroperitoneal bleed or an intraperitoneal bleed. Again, it becomes really important that if you're seeing a problem, to really use your ultrasound and your skills as physicians to really identify what the cause is. Because I would have loved one time to have the ultrasound because our patient had an intraperitoneal, retroperitoneal bleed, and we didn't know until they started to develop Collins sign. So the device actually has enough power for 60 minutes, so just make sure you're always plugging it in. And this goes for balloon pumps and any device. Always make sure it's plugged in to wall power as much as possible. You only want to use the batteries when you're transferring. And again, it also provides the purge solution, but most importantly, it actually provides recommended fixes. So you're not on your own. This device actually tells you what to do in most cases, and all you just need to do is do it. So this is what it looks like. You have your selector knob. This is, when you pick something, you rotate it either, clockwise or counterclockwise, and then you press it in to select. So you'll hear a click. So just because you move it, unless you push it in all the way, you won't actually select the recommended change you made. So the next one, these are your soft keys. We'll go over these a little more in detail. This is where you check and select things. Then you have your purge fluid door. Again, when you're changing the device, most places you go are going to have an Impella rep or a specific team come, and most of the time they just come in and switch it for you. Sometimes that's not always the case. There is a solution to doing that. There's actually a booklet. It's pretty easy, but again, if you get confused, just read the book. It walks you through it step by step, and it's actually not very complicated if you actually just go through it step by step. So here's the actual Impella controller insertion point. That's where, when you're going, make sure that that's in place. Otherwise, the whole device won't work. And also, when you're transferring, this is the first thing to go into the new device. And the reason that is the device actually tells the new device, this piece right here will tell the new device all the current settings. So it'll just restart when you transfer the patient right on to those, previous settings. So here's your soft key. This is probably the biggest one you're going to use, the mute alarm button. Because these do alarm quite frequently. And a lot of times the patients are sick, they're scared. Muting it for 2 minutes while you give yourself some time to fix the particular issue will help the patient as well. Your flow control, this is that P level that I was talking about. You can select from P0 all the way to P8. P0, 1, and even 2 are kind of used for insertion and removal. Really, the patient should not be on these, and if they are, you really need to question why. Because if the P level is less than 2, you're actually going to start getting retrograde flow down the Impella. So that's not actually a good thing. The display screens, this gives you different display menus and actually will allow you to select and do different things based on the purge fluid, based on the placement issue, or just setting it to the home screen. And again, the purge menu, this is going to be if you have problems with air in the purge line, how you're going to de-air. That's where you're going to be clicking down here. This screen, the common screen, is at the bottom at almost all times. This is probably one of the most important ones you're going to see. It gives you your current flow rate, min and max, based on systole and diastole. So based on the squeeze is what you're going to see here. Again, when you're in systole, it's going to flow easier through, and when it's diastole, the motor actually has to work harder to keep up. So then you'll see this little thing spinning when it's running. If you're not seeing that, if you're not seeing this little circle spinning, there's maybe a problem. So make sure you address that before you would leave, or make sure that the team who's caring for the patient actually sees this. So here's the purge system. This basically just looks like it's moving. As long as it's moving, there's purge fluid flowing. And of course, probably the most important one is how much battery do I have? And when I'm walking to the Cleveland Clinic or getting off the elevator, do I have enough power to make it the quarter to a half mile all the way to J31, wherever you're going? So the placement screen versus the home screen. The home screen is actually what they actually put people on in most HEM services. Yeah, it's great. It tells you, hey, position is okay. We know what we're doing. Personally, I actually like the placement screen as my preferred screen because you can actually see that everything's going to be okay. This is just the Impella controller telling you, hey, there's a problem. This is, you can actually see what the Impella controller is reading and know where or if there's a problem going to be existing in the near future. So again, you have your placement signal, looks like an aortic waveform, or an arterial waveform, right? Just a reminder that the manufacturer does not recommend this as your arterial line or your arterial monitoring. It really should be a peripheral site is what you monitor for your pressures and what you make your adjustments off of. Again, just because the sensor is right outside the aorta, so it may give you a falsely higher perfusion than you would actually expect. So really want to make sure that you have that arterial monitoring good before you leave. Then you have your motor current. Remember how I said it's easier for the motor to pump in systole? Well, you're going to see a dip during systole. You're going to see a rise in the motor current, so it's drawing more power. It actually has to work harder when it's in diastole. The big problem is again, if you're in either completely in the aorta, both ports are in the aorta, or both ports are in the ventricle, what you're going to see is a flat motor current, and you know something's wrong. Again, the case we had at Ann's, the patient had a flat motor current, but had an aortic waveform. So we knew something was wrong. We know there was a problem. And again, just keying into those cues, you can know that there's an issue with the device and it needs to be addressed. So if you have to troubleshoot and transport, probably the most common event you're going to see is a suction event. It occurs when the preload is too low, so you may see that on your central line, your CVP monitor, maybe, if you have it. Or you can just put the ultrasound on, and if the person has a completely collapsible IVC, a very small left ventricle, you're probably having a suction event, just like you would with an LVAD. So your temporary fix is going to be, you're going to select the soft key, that second one down on that soft key menu, and you're going to reduce by 1 to 2 P levels. This will take some of the work off the heart, or some of the work off the Impella, and actually allow the heart more time to fill. The long-term fix is trying to figure out what exactly is causing this. Is it a problem with the CVP, IVC diameter? Is it a proper positioning? Is the device all the way up against a ventricular wall or leaflet? Is there signs of hemorrhage or fluid loss? Was this person, severely dehydrated? Do they have an expanding hematoma? Do they have inner peritoneal bleeding? These are the things you can figure out, again, with that ultrasound. Signs of right ventricular failure, if that's the case, unfortunately it's one of those this is really bad because now they have biventricular failure and things are getting really bad at this point. And again, then you're talking about, well, does this person need, you know, epoprostenol or another kind of, you know, something to help that right ventricle. So next thing you might see is a lower than expected flow based on the device and P level. Like I was talking about, if you're looking and you're seeing that the flow rate is not in that range for your expected P level based on the device, you may have a real high SVR, so be considerate of your vasopressor uses. Again, this is not saying don't use vasopressors, just I probably wouldn't jump to phenylephrine because all it does is increase your systemic vascular resistance and make it harder on the device. Norepinephrine, again, you get a little bit, but mostly it's more of a peripheral vasoconstriction, so just be considerate of the vasopressors you use.
Is there a preference?
Typically, I've seen a lot of people on the norepi and dopamine. I don't know why dopamine, but from what I talked to the cardiologist at university, they really don't like either one. They want the patient actually more supported by the device rather than the vasopressors. Because even like norepinephrine, there is still a little bit of beta you're getting, so you're still flogging that heart. Like with epi, you're still telling that heart, work harder, even though the heart's dying at this time. So,
and are we using pressors primarily to kind of constrict the peripheral circulation to provide surgery?
Right.
Okay.
So a lot of times you'll have given maps that your cardiologist or your cardiothoracic surgeon or your intensivist want you to shoot for. So, you know, talk with the team, say like, hey, what maps do you want me to shoot for? Is, you know, a map of 60 okay? For a couple of the cases, they wanted a maps of 65, basically enough to perfuse. So we just gave them just enough, you know, norepi or epi or whatever, you know, pressor, you know, they were giving the patient. We just gave them enough just to maintain that pressure. And again, the idea is to allow the Impella to keep that pressure up. So if you can, you want to increase that P level before you necessarily increase the vasopressors. But again, if it's lower than expected, one of the things you have to consider is that person clamped down? So now you get to the really bad alarms, the placement wrong alarms. This is again one of the worst alarms you can do, because if you're either outside the hospital, you know, now you may not have a whole lot you can do for this patient. Again, we do have the ultrasound. We may be able to make a couple small adjustments, but it's a very dangerous time, because now you have a person who's requiring support who won't have any. Again, this is maybe why you're sending a lot of these patients by flight, because they don't want this person on a 3-4 hour ground transport all the way to Cleveland or all the way to OSU or all the way to Ann Arbor. So the first one where you have a problem is, can anyone tell me where this would be? You have what looks more like an arterial waveform, and again, you know that that device, the motor current is flat. It's, you know, motor current asystole means the device is in neutral, it's not working.
So it's dislodged.
Yeah, it's in the aorta. So this is actually a really kind of bad position, because the device may be completely out, and we cannot, once you're in this position, you may not even be able to advance it, because you may have to cross the aortic valve. We don't do that. This is again one where you may want to put your ultrasound on place and figure out, can you see that device sitting across the aortic valve? Is it in the aorta, just not far enough? Or is it completely in the aorta? Because if it's completely in the aorta, you're pretty much left with, okay, we're giving vasopressors and hope this person makes it.
You never try and advance it, like if they're actively dying or going.
If they are actively dying, you would have that's why I use your ultrasound. We want to use our ultrasound, and again, you would know how to advance just like you would for a transvenous catheter. If it's, you know, fairly close, or you can see the device sitting right at the aortic valve or right across it, yes, we could advance it just a little bit. And when we do that, what we're going to see is just a slight advance, you know, very slowly, 1 centimeter at a time, until you see that motor current start up again. And then you'll know, hey, I'm across. Again, tighten down your clamp, you'd be in the right place.
Is it over a wire?
No, it is actually,
It's just a device.
yes, the wire was removed, it was placed over a
Right.
wire.
Right.
However, now it's just a device. Again, that's why we don't want, if it's, when you take a look on your parasternal long, which we'll show you in a bit, and the device is actually sitting in the aorta, really don't want you guys pushing that device any.
And there's not a balloon or anything on it, right?
There is not a
it's
balloon.
just advancing it.
You can't straighten out that curved end.
No, that's just, again, to protect the myocardium from damage. So now we get one that's, actually this is probably a little bit better because this is probably the easier fix of the two. Again, you know that the motor current is flat, so you know that there's a problem. Now what kind of waveform do we have? Yeah, that's ventricle. That's why it's, you know, the pressure's so low at one point. And in this case, again, get your ultrasound out, save your image beforehand, and if this patient, again, is going to probably be looking pretty bad at this point, just slowly, 1 centimeter at a time, you can get this patient into the right, location. Most of the time, these adjustments are done very easily by cardiology because they just bring the ultrasound into the room, before you leave. Okay, we're going to pull out, advance. The job is done. You shouldn't have to do it. In the case I was on, we didn't have the ultrasound, so we didn't even have this option. It was pretty much call cardiology to the bedside and, hey, bring the ultrasound because we're going to need to adjust this device before we go. So again, if you see that in the aorta, it's going to be a little more difficult than someone in the ventricle. So placement unknown alarm. This can happen. The Impella is not even able to determine where the device is. This may just be because the person's in VFib or VTAC. So this is a little different than standard CPR and a standard ACLS. So just really pay attention to this. If the person's in VFib or VTAC, just charge and shock immediately. Don't adjust the P level. Don't do just shock immediately. Again, this is why these patients oftentimes you'll put the pads on before you even go because you don't want to be flustering around looking for the pads when something like this happens. If after that shock, the MAP, again, because you're going to be going off MAP, remains low or again, they still don't have a pulse, maybe they didn't have a pulse to begin with, but that's why, again, that's why we're going with MAPs rather than a pulse necessarily. And if the patient remains pulseless still, then at this point, switch to P2 and begin compressions and do your standard ACLS from that point. So again, this is a little different. You're gonna, again, shock, watch for a response. If you don't have a response, then switch to P2 and jump into your standard ACLS algorithm.
And why are we switching it to P2 for this?
Yeah, it's just the device manufacturer's recommendation. I guess I honestly don't have a good reason for that.
And then if you get pulses back, or say your MAP, goes up to 60, or what are you putting your P2 back at what they were on before?
Slowly ramp back up to what they were on before. You don't just crank it all the way up because what you're going to do is just cause a suction. Yeah, if you put it on boost, you're probably going to cause a suction real quick.
So are there any restrictions on the defibrillation as far as, because it's an electric device?
No.
We can use any and all charging
Yes.
modes.
So if you had to do like a synchronized, like say the patient's still talking to you, they've developed VTAC, their pressures are going down, they're starting to have more issues. Do your synchronized cardioversion, get the person out of VTAC because again, that may be beeping, saying position wrong, they're in VTAC and they're starting to go downhill. So in that case again, do your cardioversion and
What about transcutaneous pacing? You can still do that too?
yeah.
Okay.
All the devices you can do, or all those things you can do at the same time. Again, if they're on ECMO, it's going to be a little bit different because, again, the ECMO is going to pretty much take care of most of that, and all the LVAD is doing at that point is going to be just offloading that left ventricle. This is just if the Impella suddenly stops running, turn the device off, restart it at P8. That doesn't work, try restarting it at P2, If that doesn't work, again, this is like the wing has fallen off the plane and
You're all fucked anyway.
we're going down. We're just
Just trying to
Pretending like we're doing something.
we're landing in the Hudson here, so just let's hope that this works.
I don't know, unplug it and plug it back in.
You try to get on top.
Is that guy lived in the Hudson River?
Yeah, that's basically what we're looking at here. So
Started to take it for you.
here's what the device actually looks like through the heart. So in this case, here's the end. Here's your J loop over, or that J loop over here. You're sitting across the aortic valve. Here's it in like a model. This is like what we practice on at the different conferences. Again, save that nice picture afterwards, showing hey, we're definitely in the right place, or hey, when I put it in, the J loop was, that little J was right here and it wasn't working. Patient was dying. We had to advance it emergently. The purge solution, again, it's required to maintain the motor function. If it fails, the motor will become disabled, the blood will clog up the motor house and cause it to overheat, and it will stop. So this is your purge door right here. All this stuff just basically clips out. And again, if you have to replace it due to the fact that maybe the dextrose solution has run out, you may have to open that. When you spike, same thing, just like if you're spiking a bag of fluids, you're going to spike it, let all the fluid run through, make sure there's no air in the line, and then just reattach it. So depending on where you get this patient or where you're responding to the code or what you're dealing with, you may see two different types of setups. Say you're in the cath lab and you get called to a cardiac arrest, you're going to see a slightly different setup where you don't have that pressure bag solution hooked up to this sidearm. As soon as they transition out of the cath lab, you won't see this kind of setup with your Y connector. That Y connector will just have basically a useless port on it that doesn't do anything. You don't do anything with this blue port here. Again, it's only connected here during the setup phase, so if you're responding to the cath lab and you see this, again, you're not going to see this very often. It's mostly going to be this setup where you have your pressure solution and your purge solution. Even during disconnection, don't worry, you have over 90 seconds because there's a little reservoir here that actually allows 90 seconds of purge solution to flow through. Works great for when you're transferring the device. So you may run into another alarm, the purge system low alarm, where basically your short-term fix is just make sure all the connections are tight. Usually a problem with the connection being tight and the purge fluid dripping out. Also call the receiving facility and alert them that they may need to get a higher concentration, because the long-term fix is they may need to increase the viscosity of that solution. So instead of D5, they may need to put it to D10 in heparin or D25 in heparin to thicken up that solution. Again, it just kind of depends. The device is made to go from D5 in water all the way up to D40. So pretty high viscosities. So if you get a purge system high alarm, this is the way more common one of the two. And usually what it is you've moved the patient and the line has become kinked. All you need to do is just ensure that all those lines are nice and straight. And again, if that's not working, call the receiving facility because they may need to get a less concentrated fluid if they were on, say, D10. But hope that that's not the case because, again, they're going to need to get something on there to allow that fluid to flow through. Again, if there's air in purge line, you'll have to select the D-air purge system and just follow the prompts. It'll, ensure that your purge fluid is vertical. If it's hanging down over the side of the bed, you're gonna get a problem. Pick it up. That's enough sometimes to solve the problem. Ensure your tubing isn't kinked. Disconnect the yellow port from the Impella catheter. So that yellow port right here, you're just gonna disconnect it. Went too far. and then press de-air. What it'll do is it'll just push fluid through, it'll de-air the system. Then you just confirm that there's no air in the purge line, just look at the line. If there's air in there, do it again. And again, the device will tell you all this stuff. This is just kind of this is what the device is going to tell you to do. And if you need, do it again. Then connect the yellow attachment back on the catheter and you're done. And again, the device will walk you through this. So then you have the red sidearm, pressure sidearm. Same as an art line setup. Prime your tubing, get your pressure bag to 3 to 350. Close the clamp and only allow just a little drip at a time if this is on. Again, connect the device, and again, you want that slow drip going to make sure that it's continuing to flow. So transferring the device, again, the device will tell you how to do this. There's the whole manual, and 99% of the time you're going to have either a rep or someone taking over the device. Most of the time they just kind of swoop in and take over. I've only had one so far where we did it, and again, it's not very hard. You just basically do exactly what it says. Turn the monitor on, disconnect that major cable, put it into the new one. Hit OK to get your restart the prior settings. Now the patient again is on support. It was that simple. The patient is done pretty much. They are on their machine. All the dangerous stuff is done. That was easy, right? You just turn the other monitor on, pull the major cable out and put it into the new one, hit OK. So the little more cumbersome process is actually transferring the purge solution. And again, this is where you already have the patient supported. You have all the time in the world to read the book if you forget this or you're unsure what the device is telling you. Also, you can call the rep and they can walk you through it too. That's one of the things on the checklist is the device rep's number, and they're supposed to be at the receiving facility. That's their job, is to be at this receiving facility and taking this device. And the one that we didn't have, apparently they were in trouble for not being there. So the reps are supposed to be there. This is just, we train, you don't train to do cardiothoracic surgery, you don't train how to do a tracheostomy, but you know how to do a crike. You know what you're doing, even though maybe certain things are a little beyond what we do. We don't do surgeries on gallbladders, or we don't do a whole lot of reductions because ortho mostly does them. Well, you still should know how to do it in case you're in a place or location where that's not an option. So transferring the purge solution, you disconnect that same yellow lure lock, open the purge door, push the purge disc and remove the cassette. Reconnect the yellow lure lock onto the new, open the purge door, insert the cassette and select change purge fluid and select the proper concentration. It's usually D5 and it's usually already pre-programmed in. And again, the device will pretty much, walk you through it. If the device isn't walking you through it well enough, there's a manual that comes with it. So on the cart with the device. So that was a quick overview of the Impella. Again, it basically functions the same as a LVAD. So under the same principles, which we'll discuss in a few weeks with balloon pumps, kind of because balloon pumps are way simpler, and we'll just discuss it at that point. But again, you may see these patients on ECMO with the Impella, and again, that's just to offload that left ventricle with the ECMO. And again, those patients will not have pulses, or oftentimes will not have pulses. So again, really becomes important to go off your maps. If you have, show up on the floor and someone's saying this person's coding, but their map is 55 or 60, you may want to stop the compressions and just check and make sure that they still have, a map of 65 or 50. So, questions? Okay. Thanks.
Thank you.
So